examination, observation, and guidance given to the pregnant women from conception till the time of labor. What are the aims of antenatal care? The aim of antenatal care is to reduce maternal and perinatal mortality and morbidity rates and to improve the physical and mental health of women and children. What we do in antenatal care. Before this, what antenatal care does includes? It includes maternal health checkups, evaluation of fetal health and development. We offer the screening to the patient, disease screening. There are the different type of the problems which patients sometimes face during the pregnancy. Analysis of risk for the development of the complications, provision of advice and education to facilitate preparation of childbirth and to some extent subsequent childcare. Importance of antenatal care is that to ensure that the pregnant woman and her fetus are in the best possible health. So early detection and appropriate treatment of the complications again has got importance. We offering their education for parenthood and antenatal care to prepare the woman for a labor, lactation, and care for her infant. This is very important slide. As you know, during pregnancy, we offer the patient that when she has to visit the hospital. So remember, in first trimester and second trimester means from the start of the pregnancy till 28 weeks, once every month, we call the patient, and then once every 2 weeks till 36 weeks, once every week till 41 weeks plus 3 days. Beyond that, we don't go because at 41 plus 3 days, we offer the patient for induction if she is not starting on natural labor. Frequent visits advised in high-risk pregnancy. This schedule is basically for the low-risk pregnancy, which I told you that in every month up to 28 weeks, then after 2 weeks in 36 weeks, up to the 36 weeks, and then weekly up to the 41 plus 3 days. This is for low-risk pregnancy. While in case of the high-risk pregnancy, it depends. Even from starting, sometimes we call the patient in every week or after 2 weeks. How we calculate the last menstrual cycle of the patient. On the basis of this, we calculate the gestational age of the patient. You know very well. There are the two ways. Number one, by the help of the LNP, and other is the ultrasound. The ultrasound, especially which has been done in early pregnancy, I mean, at the 10 and 13 weeks in between that will help you to calculate the EDD, expected date of the delivery of the patient. While if patient has a regular cycle and she remembers well about her last menstrual period, then by the help of LNP, we will calculate her expected date of delivery. What are the nutritional supplements which we advise during the pregnancy? Yes, the folic acid. Yeah, folic acid is the one of the major, I can say, medicine which we advise during the pregnancy. Dietary supplement with folic acid before conception and up to 12-week gestation reduces the risk of having a baby with neural tube defects. And you know very well, neural tube defects are anencephaly and spina bifida. So what should be the recommended dose of the folic acid? It is the 400 microgram per day. The next drug is iron supplement. Yes, Iron supplementation should be offered routinely to all pregnant women. Early identification and correction of anemia is recommended. If patient is coming to you at first trimester and she is having low hemoglobin level, try to compensate this, replace this low HB by the iron from first trimester. And the best route is the oral treatment during the first trimester because we are having the plenty of the time till delivery. So we can correct her anemia by oral medication. But the patient comes to you in last trimester, third trimester, and she's having low HB, like 6 or 7, severe anemic that patient is, then obviously then we go for the blood transfusion because we are having very short of the time for the delivery. So it again depends okay, what will be your choice for iron. While prophylactically, we keep the patient on iron supplement throughout pregnancy. And this is also mandatory for the patient. Always encourage the patient to take the iron during the pregnancy. Few medicines have been established as safe to use in pregnancy. Yes, most of the time I can say that we face such type of the patient who are having other also issues like in pregnancy they are having the fever or they are having the urinary tract infection and so many other infected diseases are there. So in such situation, there are some limited drugs which are safe in pregnancy. So remember, always advise drug which is safe in pregnancy. We cannot advise every type of the drug during the pregnancy. Yes, exercise in pregnancy. Exercise in pregnancy, yes, we can advise to the patient, but it should be sort of mild to moderate type, not more than this. But it will be helpful for patient even for delivery. Smoking in pregnancy. There are specific risks for smoking during pregnancy, such as the risk of having a baby with low birth weight and preterm deliveries. Yes, low birth weight is seen more commonly in those patients who are having a history of the smoking. So we definitely will advise the patient to quit the smoking. The benefits of quitting at any stage should be emphasized. Women who are unable to quit smoking during pregnancy should be encouraged to reduce smoking. Yes, in clinics, many times you will patient will ask from you, Dr. Saab, can I go some far distance areas? So in pregnant women should be informed that long haul air travel is associated with an increased risk of venous thrombosis. This is the uneven risk if she is going for main arch traveling. So we will advise her if it is so mandatory and she wants to go there. So she can wear the compression stocking that will be effective and it will reduce the risk of the venous thrombosis. And along with this, we can keep her on the escort, also escort, and as well as we can ask the patient, she can change her position frequently during these traveling hours. What are the other symptoms, which usually patients face during the pregnancy? Yes. Uh, in first trimester, nausea and vomiting usually patient face, and this type of the problem spontaneously resolved at the 16 to 20 weeks of the gestation. If patient is having this type of the problem in severe in intensity, then obviously we advise some medication to patient. But if she's having mild type, so then we encourage her and just inform her that it is one of the normal symptoms in the pregnancy. Remember, nausea and vomiting are not usually associated with a poor pregnancy outcome. We can control such type of the problem if she's having even severe type. If women request or would like to consider treatment, the following interventions appear to be effective in reducing symptoms. there are the different options like non-pharmacological options and pharmacological options. Most of the time, patient opt pharmacological options, and in this category, antihistamines we usually recommend the patient. Heartburn is another symptom. Women who present with symptoms of heartburn in pregnancy should be offered information regarding lifestyle and diet modification. Antacids may be offered to women whose heartburn remains troublesome. Constipation is also one of the common problems during the pregnancy. Women who present with a constipation in pregnancy should be offered information regarding diet modification such as bran or wheat fiber supplementation, and also encourage the patient to drink plenty fluids. By drinking the plenty fluids, not only she can overcome constipation, but also other problem like urinary tract infection, which is most common also in pregnancy. So she can also prevent such factors type of the problem. Hemorrhoids. This problem usually occurs in those patients who are having already chronic history of constipation, and during pregnancy, the constipation becomes more worsening. So there are the chances that these type of the patients can have hemorrhoids too. So again, women should be offered information concerning diet modification, especially high fiber diet. We will advise the patients that clinical symptoms remain troublesome. Instead of hemorrhoids, screening should be considered if she's having pain to her right side. Varicose veins. Varicose veins are a common symptom of pregnancy that will not cause harm, and compression stroking can improve the symptoms but will not prevent varicose vein from emerging. Yes, we already just discussed like venous thrombosis. Mostly there are highly chances during pregnancy if patient is going for far distance areas, long traveling hours. Similarly, varicose vein is also one of the symptoms which usually occurs during the pregnancy, and we can advise patient that if she is having from first trimester, she is starting this problem, so there are the chances this problem can be exaggerated in first, second, or third trimester, so that's better to wear the tail stroking. Vaginal discharge. Women should be informed that an increase in vaginal discharge is a common physiological change that occurs during pregnancy. If vaginal discharge is associated with the itching, soreness, and if there's a smell or pain or on passing urine, there may be infective cause. So investigation should be considered. But if it is a watery, normal consistency, no smell, no itching, then there's no need to treat the patient. Yes, usually it has been seen that during pregnancy, candidiasis patient especially develop in second and third trimester and infection. In such type of the infection, we also advise the treatment, antifungal treatment to the patient, which is local therapy. We don't give in oral form. Another symptom that is the backache. Women should be informed that exercising in water, massage therapy might help to ease backache during pregnancy. Again, it is pregnancy related. Patient usually get worse this problem in third trimester because as baby grow, it put more pressure, and because of pressure affects mother feels severe backache. So now come to the examination. Yes, measurement of the weight and body mass index BMI. Yes, we do BMI also in clinics, and maternal weight and height should be measured at the first antenatal appointment. In women's BMI calculated, what is the formula? That is the weight divided by the height. Weight in kg, height in meters. Breast examination is not recommended at all during the pregnancy. Routine breast examination during antenatal care is not recommended for promotion of postnatal breastfeeding. Pelvic examination, again, it is not recommended at all during antenatal period. Yes, we can do per abdominal examination. We can assess the height of the fundus. We can do the, different grips are there. We can see lie, position, all things we can do by the per abdominal, but there's a no need to go for vaginal examination. Yes. For screening purpose, as I told you, that we offer some specific investigation during first trimester to the patient. We just rule out that what kind of a problem patient is having. Uh, Pregnant women should be offered screening for anemia. Screening should take place early in pregnancy at first appointment and at 28 weeks. This allows enough time for treatment if anemia is detected. This thing we have already discussed in previous slides. Yes. Other is the blood group. Blood group is very, I can say, too much important for women because women should, why we are going to offer a blood group, because if mother is blood group negative and husband is positive, there are highly chances that baby can have a lot of the such type of the antibody related problems. So women should be offered testing for blood group and RHD status in early pregnancy. If a pregnant woman is negative, offer partner testing to determine whether the administration of antenatal prophylaxis is necessary. It is recommended that routine antenatal anti-D prophylaxis is offered to all non-sensitized pregnant women who are RHD negative. So there are also screening for fetal anomalies. Screening for structural anomalies, we offer the ultrasound, that is the anomaly scan, to screen for structural anomalies. Ideally, it should be done between 18 and 22 weeks of gestation by an appropriately trained sonographer and with equipment of an appropriate standard, because this is very, very important ultrasound. It will give you all information regarding the baby structure. Screening for Down syndrome, not routinely we do in every patient. This is recommended for some specific patient, like those who are aged patients, females who are 40 plus or 40, or we can say those who are having previous baby of Down syndrome history. So in some specific condition, we offer the Down syndrome screening. So pregnant women should be offered screening for Down syndrome with a test which provides the current standard of detection rate above 60% and false positive rate of less than 5%. What are the investigation we will advise in such situations? Yes, from 11 to 14 weeks, if patient presents to you and having history of the Down syndrome in previous child, or he is aged patient, or there are high chances are in family history, then Neckel translucency, the combined test can contain NT, HCG, and PEPI. From 14 to 20 weeks, the patient presents to you, means he didn't come to you in first trimester. Onward, if she comes to you, then triple test, that is the HCG, AFP, and estradiol level, and the quadruple test that contains HCG, AFP, estradiol, and inhibitor. As I told you in previous slides that in pregnancy also, most of the time female also develop the urinary tract infection. Many of them are symptomatic and some of them might be, you may not find the symptomatic. So screening for UTI, I mean urinary tract infection, is also important. And for this purpose, we advise the patient to get done during ER and during culture. Pregnant women should be offered routine screening for symptomatic bacteriuria by midstream urine culture early in pregnancy. Identification and treatment of asymptomatic bacteriuria reduce the risk of preterm birth. Why it is important? Because even patient is not having symptoms, but if we get bacteria in her urine hair sample, so obviously again we will treat the patient because if she's having this time asymptomatic bacteria onward, there are highly chances she will start to develop in pregnancy symptoms. Even if she doesn't develop symptoms, she may present with a preterm labor pain. So as a result, preterm birth will occur. So that's better to screen for urinary infection also. Asymptomatic bacterial vaginosis, yes, it is also one of the common problems. Pregnant women should not be offered routine screening for bacterial vaginosis because the evidence suggests that the identification and treatment of asymptomatic bacterial vaginosis does not lower the risk of preterm birth and other adverse reproductive outcomes. You see, in case of urinary infection, they are, offering the routine screening, while in case of the vaginal infection, bacterial vaginosis, because there are the even we will treat the bacterial vaginosis at that time, even despite of this, you are unable to control the risk of preterm deliveries. Other infections, chlamydia, trichomonas, pregnant women should not be offered routine screening for asymptomatic chlamydia because there is insufficient evidence on its effectiveness and cost effectiveness. CMG, cytomegalovirus, CMV. The available evidence does not support routine cytomegalovirus screening in pregnant women and not should be offered. Other is, in our antenatal clinics, we usually advise the patient hepatitis B and NTHPV. Serological screening for the hepatitis B virus should be offered to pregnant women so that effective postnatal intervention can be offered to infected women to decrease the risk of mother-to-child transmission. And hepatitis C virus, pregnant women should be offered routine screening for hepatitis C virus. Yes. See, if a female presents to you, she's pregnant and she's having hepatitis B virus in her body, and she's Hep B positive. So what will you do? Obviously, you will advise her that after delivery, even baby needs to get done vaccination, immunoglobulin. Okay. So for this purpose, these screening tests are very, very important. HIV infection, yes, pregnant women should be offered screening for HIV infection early in antenatal care because appropriate antenatal interventions can reduce mother-to-child transmission of HIV infection. Rubella IgG we offer the patient. It should be offered early in antenatal care to identify women at risk of contracting rubella infection and to enable vaccination in the postnatal period for protection of future pregnancy. Again, you see, if female is having rubella IgG negative, then it means it is not immunized. If it is not immunized, what we will we do? We are not going to give her, vaccine against the rubella during the pregnancy because it is a live vaccine and live vaccine is not recommended during the pregnancy. So after delivery, we will give this patient vaccine against the rubella. But during pregnancy, if she is rubella negative, we will tell her about all precautionary methods that are even if she start to develop any viral fever or rashes, so what sort of the precautions she has to take. So this is the significance of this test. Streptococcus group B, pregnant women should not be offered routine antenatal screening for group B Streptococcus GBS because evidence of its clinical effectiveness and cost effectiveness remain uncertain. Yes, routine screening for gestational diabetes mellitus should be offered to all pregnant female. At first contact, a woman develop risk of preeclampsia should be evaluated so that the plan of her subsequent schedule of antenatal appointments can be formulated. So, especially for gestational diabetes mellitus, in first visit, we advise the patient fasting blood sugar or running blood sugar and later on, after 22 weeks of the gestation. In gestation, we advise the patient for OGTT, that is the oral glucose tolerance test. Okay, so it is very, very important to screen for diabetes mellitus because there are the chances that some patient may develop gestational diabetes after 20 weeks of the gestation. And also for preeclampsia, but we do screening for preeclampsia in those patients who are having the previous history of the preeclampsia are in this pregnancy, there are some parameters which we are feeling that they are going into worsening pattern and she may develop preeclampsia or symptomatically. So then we will do screening. So developing preeclampsia during a pregnancy is increased in women who are nulliparous, who are aged 40 or older, have a family history of preeclampsia, have a prior history of preeclampsia, have a body mass index BMI that is 8 or above 35, first contact means that she is obese, have a multiple pregnancy of pre-existing vascular disease, for example, hypertension or diabetes. In such situation, we will advise the patient for screening. Whenever blood pressure is measured in pregnancy, a urine sample should be tested at same time for proteinuria. Means how gonna be screen such patients? Obviously, we check her blood pressure, and along with this, if we find out that she's having high blood pressure, so we will advise her some also other investigation in which urine for albumin that will show the proteinuria whether it is a positive or not. And if it is a positive, there are some also other investigations like uric acid and liver function SGPT we will check out and CBC platelet counts. You know very well, preeclampsia can be complicated to the eclampsia and even DIC patient can develop because of this problem and HELP syndrome. Preterm birth. Routine vaginal examination to assess the cervix is not an effective method of predicting preterm birth and should not be offered. Although cervical shortening identified by TVS transvaginal ultrasound and increased level of fetal fibronectin and are associated with an increase for preterm birth. Okay, so this type of the thing, I mean, if you are getting short, cervical length, so definitely we offer most of the time patient ultrasound, and if in ultrasound it is proven that patient is having shortening of cervical length, then we advise accordingly the patient. Remember, neither routine antenatal cervical assessment by transvaginal ultrasound nor the measurement of the fetal fibronectin should be used to predict preterm birth in healthy pregnant women. These both are not 100% markers that will give you information that this patient is 100% will go in preterm labor. No, not at all. Now come to discuss what are the common these problems which you will find in pregnancy. Yes, one of the common problem is anemia. Other is the pregnancy-induced hypertension, gestational diabetes mellitus, urinary tract infection, fetal anomalies, Down syndrome. So such type of the problem will be screened during the pregnancy. How we assess the fetal growth and your well-being? Yes, by abdominal palpation for fetal presentation. We do for abdominal examination. We check fetal presentation should be assessed by abdominal palpate at 36 weeks or later when presentation is likely to influence the trends for the birth, and suspected fetal malpresentation should be confirmed by ultrasound. If you are suspecting by abdominal examination that baby is not lie or reach, then obviously for further confirmation, it is recommended to advise the patient for ultrasound. And if in ultrasound it is reach or transverse lie, then there is no need to give this patient normal trial. Obviously, then she will be candidate for cesarean section. Height of fundus, yes, you know very well it has got very importance. In each visits, you will check the height of the fundus of the patient in every antenatal appointment, and by the help of some simple fundal height, you will definitely roughly, or I can say clinically, will diagnose that the baby is going well or not, is growing well or not. Okay, if it is corresponding to the gestation age of the patient, it means everything is under control. But if you feel something like fishy, I mean suspicious, like less than the gestational amenorrhea or more than gestational amenorrhea, in such situation, again, we offer the patient for ultrasound to confirm it, whether baby is growing well, everything is inside there well, I mean, amniotic fluid, and what is the position of the placenta, everything we confirm by the help of ultrasound. During height of fundus, I mean, per abdominal examination, when we check the height of fundus, obviously, again, we then and there we auscultate the fetal ultrasounds by help of sonicate, and to confirm the, I mean, by the help of sonicate, whether baby is having normal fetal sounds or not. CTG is not recommended in every patient. Yes, it will be helpful for you during, I can say, the time of the delivery, at the time of labor, because it will give you information regarding the baby fetal heart rate. And again, you know very well what is the normal fetal heart rate, and it should be in between 110 to 160. If it is less than 110 or more than 160, again, we make decision accordingly. In ultrasound, yes, ultrasound is the one of most important investigation during pregnancy, because it will help you to assess the growth of baby, amount of lichens, placental localization, fetal weight. Umbilical artery Doppler, we do not recommend in every type of patient, I mean every patient. There are some specific condition where we go for the umbilical artery Doppler, where we are suspecting the IUG or intrauterine growth restriction. Our patient is having high BP. There are the chances that baby can have idea, our baby is microsonic. In some specific situation, we will advise the patient of like artery Doppler ultrasound, and again uterine artery Doppler ultrasound after the patient in some specific condition. Yes, as I told you, schedule of antenatal visits that up to the 41 weeks plus 3 days we wait for normal labor. If patient doesn't go in normal labor beyond this, then we offer the patient for induction of labor. So if patient comes to you 40 plus 3 is the ideal time. Up to the 41, again, up to this, okay, we can go, but much better that 40, if patient comes to you up to the 40 weeks and having a 1 or 2 day over, try to induce her, no need to wait more. Prior to formal induction of labor, women should be offered a vaginal examination for membrane sweeping. Yes, it has got very important role, membrane sweeping. Women with uncomplicated pregnancy should be offered induction of labor beyond 41. No, not at all. We are not offering here beyond 41 weeks, because in our country, patients are not so cooperative. I can say, if I just tell them after 40 weeks, come daily and get CTG done and make sure everything's going fine, they are very reluctant. So here we offer up to the 40 plus 3, not beyond this. So that's all about my presentation, and I'm going to upload this lecture and also some DCQs. Thank you very much for your time. Allah Hafiz.
डॉक्टर हमारी हैंड रेस करवा लें स्टूडेंट से सब।
अच्छा, हैंड रेस करेंगे स्टूडेंट भाई, बच्चे कर लो जी, तो करते जा रहे माशाल्लाह।
एक मिनट, हम लोग नोट कर रहे हैं ये
57, 59, 37, good. 8, 17, good.